Larry is going to speak to us on publishing. He said publishing for poets, how to write opinion pieces and more. Do you want me to read your bio, Larry? Do you want to introduce yourself? What's your preference?
I'm happy to introduce myself if you'd like, Jen, whatever you'd like.
Sounds great. I'll just say that like we have wanted you to give this talk for a while. Larry has really like cracked the code on finding ways to publish really informative, actionable pieces in really top tier journals, and really help bring a lot of the things that we all care about to a broader audience, especially a clinical audience. So I'm excited to learn from you all today, and I'll turn it over to you.
Awesome. Thank you so much. I really appreciate the invitation. So thank you, Jen, Bree, Lisa, and Arch Network members and the Amend folks. It's a pleasure to be here. I'm often on these listening in, but long time listener, first time caller. So I'm gonna get on my presentation here. Let me know if you can see it. And I should just share my screen, correct? Let's see.
Yep.
Does that look good to?
It's coming up.
Okay. Does that work okay?
That's perfect.
Awesome. Okay, I'll just say a word about myself and then get into the presentation. And just to remind myself of time, is it about 45 minutes or till 2:45 or so? Is that the goal?
About 45 minutes, yeah. And sorry, you threw me, but about till 1:45, 1:50 would be great. Yeah.
I'm sorry. I'm on Mountain
Whatever
Standard
time zone
Time.
you're in,
There's
exactly.
disclosure. So I'm in Denver. So I'll make that my introduction. I'm Larry Haber. I'm a hospital medicine physician at Denver Health and the University of Colorado. I've been here about 4 years now. And then before that, I was at UCSF and a hospitalist at San Francisco General Hospital for about a decade. For that, I did training at UCSF in internal medicine and a primary care pathway, worked briefly for the Northern Navajo Medical Center on the Navajo Reservation after training, and then returned to did a hospital medicine fellowship and kind of launched into my hospital medicine world there. So I'm going to talk today about publishing for poets. And so I'm going to go through different venues for publishing for folks who don't consider themselves necessarily big R researchers or who do and still want to publish other types of articles, and then really focus in on perspective pieces in particular, and kind of go through at least the approach that I take with my my collaborators to make a perspective piece. And then if we have time, I'm going to take us through a fake perspective piece that we'll just build together. Okay, so some disclosures, no financial disclosures to report. Wouldn't that be nice if there was? I was an art history major, so I kind of come from a liberal arts background, and I think in some ways that also informs my approach or my interest in writing. And I really enjoy kind of trying to put down in words the experiences that we have as clinicians, as advocates. Oh, Erin, I didn't know you were an art history major too. Welcome. That's the reason we get along. So I enjoy writing, and I approach some of this from a liberal arts background. I am, so I'm a funded clinician educator, and I have funded roles through the School of Medicine. I do work in faculty development for a group at Denver Health, and then I direct our longitudinal medical student coaching program in our UME curriculum. So that's all to say, I also approach this work with like a clinician educator side, and I like to think use some of those educational tools to kind of shape how I create pieces and then sell this to an audience as well. I can be a bit lighthearted, even irreverent at times. Please know that's both me being nervous and just kind of how I present. But no, I take this work very seriously, and the work that you all do, I think, is supremely important. So please excuse any foibles. These views are my own, may not be representative of Denver Health, certainly, or the University of Colorado. Okay, so our objectives here, I'm going to go through kind of in the first third, actually just review various avenues for publishing kind of non-research related articles. Okay, then I'm going to shift gears into specifically drilling down on how I build a perspective, and this could be different across different people. I think Dr. Kavinsky talked a couple months ago to the same group too around kind of more perspective pieces. I thought it was really helpful for me to hear him and where we overlapped and didn't. And then I'm going to review just some common tips for writing, submitting, revising an article, kind of some nuts and bolts, like in the weeds a bit more. And then if we have time at the end, just create an imaginary perspective about kitten injustice. So I'm kind of a cat guy, but I'm also turning into a dog person. Okay. Please stop me if you have any additional questions or anything going on throughout the course of this. I kind of it's like when you're talking on Zoom, lecturing on Zoom, it kind of goes out into the ether. You all are much more engaged than the medical students here. So I think why publish, these are some reasons that I just use to motivate myself when I'm like gearing up, because as I said, this is unfunded work that I do, and my funding comes elsewhere and kind of independent of these streams. But one, I think of advancing science in terms of like the biggest picture here. How can I contribute to advancing science with the idea that if I do that, I'm going to improve patient care. I'm a clinician. I spend about half my time seeing patients in the hospital at Denver Health, which is our city's safety net hospital. So I think about how am I going to use this to actually improve the care of the patients I see and that other people can. And then I think this is no particular order. I like to use the work to highlight a unique patient population. So I've worked at San Francisco General, I worked for the Northern Navajo Medical Center, I work at Denver Health, I've worked with a lot of, I'd say, marginalized populations. I have a particular interest in the care of those populations as well. I find that a lot of what I read in the medical literature doesn't always pertain, or that the populations that I care for have been excluded from the study, et cetera, that the medications that are, the hot new thing my patients don't have access to. So I think a lot about how I can actually bring the work that I do with the populations that I see back to like the medical literature and disseminating that. I like it also as a way to communicate with colleagues. I use this as a way to stay in touch. I use this as a way to build a community that sustains me in my other work and in this work as well. I think if you're interested in established expertise in a field, I think that especially the work that you all do is really interesting, novel, and just so increasingly important, especially right now. I work in an academic environment. I direct actually like faculty development and academic advancement for our group here. So I also just think about, how do I kind of demonstrate my prowess within the university and make sure that I'm getting promoted and accurately compensated for what I'm doing. So this is an opportunity through publishing to demonstrate academic productivity. It's a very concrete measure that universities will look at when we're up for advancement. And then this is the more kind of big picture ethereal concept, but I, in a romantic sense, think about contributing kind of this everlasting body of knowledge that is the medical literature. And I think that that's like a beautiful thing at the end of the day that will well outlive my career and me, hopefully, but still be of use to somebody centuries from now. The kleos, the immortal glory that comes with publishing, right? Just think about the landscape of kind of the journals that we're looking at here. So some journals are owned by medical societies, others by health organizations, others commercial. For example, the Massachusetts Medical Society owns the New England Journal of Medicine. The AMA publishes JAMA and all of its kind of subjournals. The American Heart Association produces Circulation. And then there's this handful of large commercial publishers that produce most other medical journals. There's probably a discussion for another time about that. But just know that there's tens of thousands of medical journals published around the world. And I think most people who are active in publishing think there's a home for anything. And I tend to believe that. It sometimes depends on how far you want to go. Just brought up this one. I was searching for various medical journals. This is a research and drama education, admittedly not medical. I just put this up here to prove that there's probably a home for most things that you can think of. You just have to get it in the right place. So to get into it here, I am not a big R researcher, but if I'm not that person, or even if I am, what can I publish if I'm not a researcher? I chose this doctor because he looked exactly like my arch nemesis in medical school. So we're going to explore a few types of articles here to get our feet wet here. I'm going to go through reviews, perspectives, we'll drill down on that a bit later, letters to the editor, narrative pieces, case reports, clinical images, and then just some prescribed article templates that I find just interesting in terms of I just have to have a concept and they're going to tell me what to do. And I think that's a great place to be sometimes. So in terms of reviews, I think of this as like, a particular body of literature and you want to tell people about it, like you know it well, or just because of the research you've been doing, you've actually developed this expertise in even all the background literature that exists that you needed to go forward. And when I'm thinking of reviews, not really a researcher, I don't have a whole lot of skills in data analysis. I'm thinking of narrative or scoping reviews rather than systematic or meta-analyses, systematic reviews or meta-analyses. The narrative review theoretically is something that identifies like studies that describe like a problem of interest. And again, I'm going to show you some examples. This can be whatever problem of interest you're interested in. There's no real predetermined research question. There's nary a specified search strategy. There's really just a topic of interest. And then you take that body of literature and you summarize and synthesize the findings from the article into a digestible piece of literature for somebody. A scoping review, I've been seeing more and more of these. This is ideally like an exploratory review, addressing like a broad question so that you can get a sense of what is out there, like what is the available evidence, put it into groups, highlight gaps so that you can inform future work to follow. I think of these review categories as essentially there's enough literature to review. There's not one or two articles on the subject, but there's not enough to systematically review, or I'm really going to have to get in there, get all the different data, crunch some numbers, come up with new tables, etc. So I often think to myself, and this is maybe more for the clinicians on the call, when I'm looking at like up-to-date resources as a quick guide, I think, could this topic fit into like an up-to-date resource? Like if I just had to kind of categorize it, like an introduction, the signs and symptoms, like evaluation methods, treatment, etc. And could I fill out that same format on my own? I would also caution you to make sure it's not already an up-to-date article or that this doesn't already exist. Sometimes I've found that my beautiful idea was beautiful 20 years ago as well. And many, people have already captured it. And it's already there. So these are some examples of just the kinds of reviews, just to give it a sense of the breadth. Actually started out, this was the first narrative review from 2018 that I did, which was really just born out of my own clinical uncertainty in terms of best practices in care in the hospital for transgender patients I was seeing that was hospitalized at San Francisco General. Got together my colleagues and we started to say, gosh, you know what, when I did a quick up-to-date search in my clinical practice, there wasn't anything, I didn't find anything. So then I went to the primary literature. Gosh, what's out there? And is there a way, after I started looking through this literature and trying to inform my own best practices and what can we systematically do in the hospital to improve care for patients, is there a way that I could organize it and present it to others that might actually help them and their institutions codify this care better? So again, I just lay it out there. So we included terminology, how to address transgender patients, obtaining inclusive history that takes into account gender-affirming surgery, managing gender-affirming hormone therapy in the hospital, considerations for hospitalized patients, interpreting lab values, just kind of laid it out category by category, legal issues, considerations for health systems. We define these categories. Did a similar one then a number of years later for acute care for patients who are incarcerated, again, using a similar framework. And there was a similar, I'd say, like sweet spot of literature that probably existed, but then put together, made a lot of these, like put it into categories, I think that hopefully made sense to people. It doesn't all have to be for clinical care. I think it could be for practices or concepts as well. I'm interested in peer feedback from a faculty development perspective. So we put together a narrative review looking at peer feedback to promote clinical improvement within hospital medicine. What literature exists, how can we apply it, what's missing, and what are next steps? Did it for clinical work as well, a low anion gap. This one's pretty esoteric for the clinicians on here. And then looking at care by a certain type of provider, for example, nocturnist, hospitalist practice only overnight. And how do we, again, categorize it, look at the available literature, and deliver it to interested people. Perspectives. I'm going to say more about this. So I'll be brief here. These are ideas and opinions, viewpoints. You'll see them kind of called different things in different medical journals. I think of this as like, you have a point to make about something. You're Homer Simpson there, and you're kind of like, angrily decrying a point there. And this is either a point that hasn't been made or that you don't think has been made well, or something you disagree with. I find that can be driven by your absolute certainty or absolutely the uncertainty you want to cast on something that's widely accepted as the norm. These are generally short opinion-based articles, and so they can address a wide range of topics. You just have to find, I think, the right venue for them, either a targeted journal or a general enough journal that captures all these kind of items here. They're generally not linked to a specific article, although some of them can be solicited by the journal as invited commentary on pieces. I would also encourage folks, as you look through your target journals, your journals of interest, look for special calls that are related to article types. So for example, calls for articles related to climate health, articles related to women's health, articles related to artificial intelligence in medicine, or whatever it might be, because you already know then that the journal is interested in something you have to say about the topic. Like there's an opening there. And so I think if you see those and you think you have an idea, I would try to get your foot in the door. The perspectives generally have a lower word count, usually like 1,000 to 2,000 words, maybe on the maximum end, but usually around 1,000 or 1,200 words. So they're pretty minimal in some ways, and they often have a pretty restrictive reference limit of even 5 to 10 references, because again, these are supposed to be, grounded in the real world, grounded in evidence, but also have some of that eminence base as well. They want to hear your perspective, your argument, your opinion on something. They're generally found in most medical journals. And I kind of think of this as a journal's attempt also to game the system a bit in terms of like looking at something like impact factor, which is kind of one measure of success of a journal. The higher the impact factor, the better. So total citations over total citable articles would be the way they calculate the impact factor here. So anything that increases the numerator or decreases the denominator is going to be good for them. In terms of total citations, things like perspectives, anything that falls into editorials, they count towards citations. So if you then cite an editorial in your next paper, it rewards this journal, but it actually doesn't count towards their total citable articles, which are generally like reviews and like original research articles. So in a way, it's to the journal's advantage to present, to offer perspective venues for folks, because if they're then cited in the future, it increases their impact factor. These are some examples that we've done. So intersection of climate justice and criminal justice, and this was in response to actually a call for climate change and health section. This is in JAMA. Medicaid for medical correctional care, time to manage what is reimbursed. It's the most jargony kind of mouthful of a title I think I've ever constructed. This was in JGIM as well. Staying against medical advice. This is for folks who stay after we've discharged them, which turns out to be a relatively common hospitalist problem that hasn't been written about. Can my incarcerated patient discharge against medical advice? These are all just perspectives. Decoding homelessness. So it's writing about changes to reimbursement of the Z codes and how it elevated homelessness as a comorbid condition and the importance of that. So again, wide array of topics and across journals. This was Journal of Hospital Medicine, JGIM, JAMA. Stop me at any point if you have any questions, comments, disagreements, please. I'm just talking here.
Larry,
yeah.
I want to ask you a question. So the review article several slides back, do you remember how you submitted them? Because I've read at least the transgender and the incarcerated one. And did you submit them as, how did you label them? They're just labeled as review, but what would you consider these two articles to be? Scoping review, narrative review?
I would consider these narrative review. Yeah, it doesn't explicitly say it here. I wrote these as narrative reviews. I've never written a scoping review. I reviewed some scoping reviews. I have to say that in my mind, the difference, I'm sure there's people on here who would know better than I, but from what I've read and seen and reviewed, the difference in my mind between the narrative and the scoping is slim. I similarly, using these narrative reviews, I identified gaps in the literature, next steps, those kind of things. So I found them to be very similar. There are differences, but these were billed as narrative reviews. And then the submission process, for example, for JAMA IM, where both of these were published, has gotten a little more stringent, I would say, in terms of just pre-submission inquiries, having to really demonstrate the need that this review fills, having a pre-submission approval, then to even just start the process of submission. And then, for example, get still rejected as our Nocturnus one did. But we were persistent and it kept going, and hopefully eventually I got it to a home where people read it. So, but they're getting, I think, a little more particular.
Thanks.
Yeah. All right, letters to the editor, also known as correspondence, for example. I think of this as like, I have a very short point to make about something here. And so this can be one related to a published article. So something came out, I read that article that was of interest to me, or it's in my field, and there's something maybe that I thought was incorrect. I mean, that's probably few and far between. And I'm a little less likely to just really write in about my colleagues' work and disagree with it, but maybe I disagreed with an assertion. Or maybe it's just a missed opportunity, or maybe there was just something that I noticed out of the article that I think they probably didn't even have time to mention because of all the other things they were talking about. These often need to be submitted within a really short time frame, so you got to strike while the iron's hot. I think about this when I'm kind of reading through, published online. I get those things in my, inbox, and I read through them because also the time to submit is from the time they were published online rather than the time they were published in like the full like table of contents. So I want to make sure if I see these things and they're of interest to me and I read the article and I think, gosh, you know what? I might be able to add something to that, or I had a question about one of their methods, etc. I probably want to do so within about 4 weeks or so. Then there's some formats where you can write a letter that's not in relation to a published article. I think these are a little fewer and further between in my mind, but I could be wrong. I think of, again, these ones like a very small perspective, and we're talking like 250 to 500 words. These are very brief. This is kind of something people should know or think about, but not much more. Like I had this idea that I just wanted to get out there into the world, because maybe I plan on doing something with it later, or I hope somebody else takes notice and does something with this. These are some examples. This one was in one of the Lancet subjournals around measles in jails and prisons. Again, just a general, like, I'm concerned about this. I wrote this with Drs. Russell and Justin Burke at Brown. Something that I was just concerned about, and I think we could make a reasonable case that others should be concerned about it as well. Hidden crisis of incarcerated individuals during wildfires. This was in response to the wildfires that were in Southern California last year. I wrote this with Caitlin Masters, who, she's on this call, that's a member. And then this was a letter in response to an article published in JGIM around shackling practices in the hospital, which is a particular interest to me. And I know a number of other folks on this call, like Aaron, Vera, folks who've written about this before. Just kind of going through the proposed algorithm and just honestly, slightly but gently disagreeing with one part of the algorithm. This was actually an article in response to an article that Aaron wrote, actually, around a wonderful article around surrogate decision-making practices for hospitalized patients that are incarcerated. And we just wanted to, and I think Bree and I wrote this one just highlighting the interesting aspects of cooperation between the correctional officers and actually the medical providers. Narrative pieces. So this is like you have a story to tell. These can be used to describe or highlight any content. I actually think of these as being able to be used in future work as a case. So in some ways, many people, I think, would use these indistinguishably in retrospect from a case report, but allows much more subjectivity. You can use both emotion and reason to prompt discussion or consideration. And then I would say you can use some data, some citations. My own bad habit is to try to veer into like a narrative review when I'm writing a narrative piece, which probably not what I should be doing. But I know myself. And then I would just say it better be captivating, right? This is a narrative piece. The work that we all do in this field, I think, is extremely captivating when described in kind of some of also its like most shocking terms, I think, in terms of the harms that people suffer in carceral facilities or upon release. So I think there's a lot there that we can bring to also folks who are outside of this world, either in medical fields or in the lay public as well. I would say caution with revealing identifiable details, certainly about patients with all of these, but also coworkers. I got some pushback on one of our articles we wrote. There was a narrative piece where the editors were, I think, appropriately concerned that the coworkers of Dr. Bonsall here could have been identified in the paper. And so we really had to take out any details there. So we wrote again about a case, and this is Amar Bonsall, who's a doc in Pittsburgh. I was just providing some of the background context and editing on this, but this was really his narrative piece around taking care of a patient who was sedated on vasopressors in the intensive care unit, yet still shackled to the gurney, and using his experience to talk about that. This was a more lighthearted one, talking about my colleague who, for the life of him, couldn't perform a lumbar puncture. We used a baseball analogy to discuss kind of failure in medicine. So again, it can be wide-ranging and variable, and it can either be really honestly like pretty traumatic and tragic, or even on the more lighthearted end, hopefully, but used to address something serious. Clinical case reports, I think of this as like, well, you have a case to present. This is kind of, I think, bread and butter for clinicians and something that we're used to seeing. Detailed reports, symptoms, testing, treatment, follow-up of either a single patient or a series of patients. Again, this might require you, if you're a clinician, to save details, lab imaging, findings, follow-up, and those kind of things. I would say, again, caution with revealing details about patients. Some of these require patients to actually sign consent forms. These are like these are clinical reasoning exercises. For example, JGIM has a very common one. The New England Journal has a common one, where an expert clinician goes back and forth and describes how they would think through a case. This was just like a fascinoma of a case. Clinical images. So this is, you have a picture to show someone, right? And this is usually like some classic disease process or unusual disease process that everyone gets a kick out of. I honestly tend to have my own pet peeve about this, is that I think you could really use clinical images to show something very important because they're really dramatic, and probably draws from my art history background. Here I am bad-mouthing something like the New England Journal, but I feel like they could use their clinical image section to like, and the expansiveness and depth of the audience they reach to actually make a little more profound points, instead of the fascinomas. So I think of these as chances to make an interesting point. Again, a lot of caution with revealing details about patients. Now that I've badmouthed the New England Journal, I do want to give them huge credit here. Just recently, they actually had an interesting section on climate health, and they actually published this interesting clinical image around a patient with a psychotic disorder who was walking during a heat wave on the streets and suffered severe burns requiring hospitalization at a burn unit. And so in my mind, this was actually using a clinical image to really say something, one, clinically, but then a little more big picture in terms of policy as well. Similarly, tried to do this with a shackling ulcer that we identified at San Francisco General, which was an ulcer secondary to like overly aggressive shackling to the bed frame during hospitalization. And not only using it as an example of like, gosh, clinicians need to be aware of this, but also we need to think about this from a policy and ethics perspective. And then finally, prescribed article templates. So this is often, you just want to be told what to do, and there's nothing wrong with that. These are well-circumscribed templates that offer very clear guidance for you to kind of fill in the blanks of different sections. It might not always be applicable to what you want to cover. It may require some shoehorning if you have a topic of interest and you want to try to fit it into a certain template. And some of these, if they're very popular, may have big backlogs on barriers. Or barriers in terms of big backlogs. The world, I'm a hospitalist, so I travel in the Journal of Hospital Medicine, for example, which actually has some wonderful prescribed templates as part of their Choosing Wisely series, the things we do for no reason. So trying to describe less is more practices. I have a particular interest in substance use or management of substance use disorders within the hospital, so I tend to write about that a lot as well. So we looked at, again, kind of prescribing vitamins for folks with alcohol use disorders, prescribing buprenorphine, and policy changes that eliminated the X waiver for prescribing, management of patients who are using methamphetamine, and how do you manage those folks in the hospital. But again, these were all very prescribed article templates that required us to kind of put our ideas into their format. Okay, I'm gonna then hone in on perspectives, particularly in the last 10 or 15. But let me know if there's any questions. I was speeding there. All right. A brief reminder here, and this is always a brief reminder to myself as well. I don't want to assume everyone holds the same opinions, belief structures, or values as I do. And I've been on the receiving end of that reminder a couple of times. We all exist in particular ecosystems that may not represent most people or settings. So I try to go proactively into these perspectives thinking, okay, what is the other side of the argument, or what is a counter argument that somebody might make? How would I convince somebody who didn't already believe this? And that's really what I want to do too. I don't necessarily want to preach to the choir. I want to try to reach people who maybe don't believe this or haven't thought about it, maybe. Or even don't believe it. I usually try to think about moral, medical, monetary arguments to attack this from a couple of different angles here. And I want to be ready for disagreement. I want to just be ready, but I know that that is kind of part of the ecosystem of publishing these kind of pieces. So let's start about it. Title. Okay, I want to make this really clear and eye-catching. And again, this is just my framework to how I think about this. I want to tell the reader what's inside. I want to go bold. It's a perspective. It's not a randomized controlled trial or something. I can go bold. And really what I want to do is I just want to grab somebody's attention as they're reading through like their 50 emails that they opened up on that Monday morning, and they see, the table of contents from, 10 different journals. I just want them to be intrigued enough to click on the link, intrigued enough to just go ahead and read that first line. So I want to get them with the title and just take them to the first line. And this is going to be my whole approach. I'm just going to try to shepherd them through the article. Okay, so criminal justice reform is healthcare reform. You might agree with it, you might not agree with it. Want to read the first line, see what you think. Decoding homelessness, Z codes and the recognition of homelessness is a comorbid condition. Kind of fancy. It's got a fancy subtitle. I think sometimes subtitles are good or bad, depending on how bold you want to be or not bold. It gives people a little more idea of what's inside. The hidden crisis of incarcerated individuals during wildfires. The intersection of climate justice and criminal justice. Extreme heat and health inequities in carceral facilities. Threats to women's health in prison and jails. Wrote this with Jen Rui. And then, again, this is from like some of my favorite titles to honestly, the one at the end is one of my least favorite titles. I think it's the most jargony thing I could imagine. I don't actually think that most people would want to read that. So if I had to do it over again, I really like that article. I'm proud of the article, but I probably would actually title it something that was a little more eye-catching. So after I've hopefully sucked you in with an eye-catching title on this perspective piece, which can be pretty bold because it just has to be rooted in my own perspective or opinions for the most part, I'm going to try to go big with the first line. I'm going to tell the reader why this is important, why they should care, why they should just keep even just reading a little further. So I'm going to go big with the first line. Sometimes I consider a case to draw people in. So something that might get a clinician's attention, something that might get a researcher's attention, something that might get a lay reader's attention, something that's dramatic and sets the stage for what I'm about to discuss. I want to describe the magnitude of the problem. I'm going to try to use impressive numbers or statistics just to put it out there to show the magnitude. I'm going to show how this disproportionately impacts certain populations, or like alternate, I'm going to show how everyone's affected. I'm going to titrate a bit of the background to the audience. If I'm writing for a general medical journal, I may need to provide more background on the topic than less. If it's a very specific journal where folks may already be familiar with the background, I may be able to lessen it. I'm going to try to create a little tension here. So although this problem exists, like this is the magnitude and it's hurting these people and it's hurting everyone. And although that is true, very little is being done about it. This problem is killing kittens. We need to do something about it immediately. And then I'm just going to tell the reader, frankly, what I'm going to deliver. I'm going to manage their expectations in the last sentence or the last paragraph. I'm going to say, we're going to discuss X, Y, or Z. I'm going to try to head off in advance the things I'm not going to talk about so that people know what they are or not getting, so that a reviewer knows what they are or are not supposed to review. Doesn't mean they're not going to tell me that they wish I had included X, Y, or Z, but I'm going to try to do it a little a priori. So, the US imprisons more of its population than almost any other nation, a phenomenon known as mass incarceration. Okay, that's a dramatic first line that I'm trying to hook the reader in here. I'm going to describe a magnitude of some problem. So there's 653,000 people across the United States experiencing homelessness. Homelessness is an important social determinant of health with increased morbidity and mortality. So I'm trying to give them a sense of the magnitude of the problem. I'm trying to tell them that despite this many people experiencing extreme heat, very little is being done about it, and about 25,000 people might die because of it. And then finally, for example, this is what we're going to deliver. We're going to review the purpose of the Z codes. We're going to describe how CMS policy change is elevating the importance of homelessness. We're going to conclude by calling for health systems to move beyond simply documenting homelessness to meaningful addressing health inequities in patients experiencing homelessness. So again, just kind of taking the reader, even that introduction section, through what I'm going to hopefully deliver on a platter for them. In the body here, I'm going to take the reader on, again, a clear guided journey. I like to use section headers. I find that they help organize me and they help organize the reader in some ways. So rather than just paragraph, 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 I'm gonna provide them with like, this is what I'm talking about in this paragraph. This is what I'm talking about in the next paragraph. So I think it forces organization and tells the reader what they're going to get. I think it leads from one section to the next. So hopefully it all makes sense for them. I'm a hospitalist. I think a lot about handoff. So it's like the warm handoff from section to section. Okay, now that we've completed that, I'm going to go on to this next logical place. Honestly, if the headers aren't working for you, or if the argument's a bit more nebulous, or I even find if sometimes the sections are terribly unequal and it looks visually kind of unappealing, I just get rid of the headers so it's not obvious. I find that brief historical notes can provide context or deeper knowledge. So if you want to do those deep cuts from, this X Act of 1963 that demonstrated X, Y, or Z, or this deep policy kind of thing that you want to bring to a general audience, I think it helps sell maybe your expertise a bit more. I don't shy away from providing examples. I think a lot of things sound good or bad in theory, but then centering the reader back in reality can actually be helpful through concrete examples. It could be through cost analysis, example cases, real world resources that you want to provide somebody. And then finally, I always consider presenting the other side of the argument like ahead of time. So rather than waiting for a reviewer, rather than waiting for somebody to write me a nasty email, I want to address it up front. So I don't want a skeptical reader to dismiss it outright. I want to attack it head on. And it might mean acknowledging some uncomfortable realities or lack of evidence. So, for example, this was one we wrote about extreme heats in carceral facilities. So susceptibility to heat, then we talked about how then folks are systematically exposed to environmental hazards, and then how the mortality because of that was generated and how this was underreported, and then led into the conclusion there. Brief historical notes. So I love talking things like Estelle v. Gamble from the Supreme Court decision in 1976, just to provide people with like a little bit more background, feel like they're really like learning something deep about it, even if at the end of the day, they're reading a 1,200-word essay. This was like from another health and climate change article. So brought people back to kind of reality, presenting things like the Toxic Prisons Mapping Project. So this is something somebody could then just Google and actually bring up a helpful resource and see that these things actually do exist. These are not just kind of abstract concepts that we're presenting. This was one actually we wrote about shackling in the hospital and tried to address head on. Well, what's the counter argument? You know what? Maybe shackles actually do wonders for people. No, it turns out they don't when you look at the literature, but I think it was helpful to address head on before we discussed all the other evidence-based ways that they're harmful for folks. And then finally, when I'm kind of leading up to the conclusion here. So this is a time in my mind for aspirational vision based off of what you presented in the body there of the text. It doesn't have to simply summarize the discussion. I think like a research article, it's time to play a bit with the results. I like to discuss what could be done differently, how we can change, what kind of things are needed for change, what barriers we need to overcome. I think there's a balance here in terms of grounding your aspirations still back in reality. It's not a complete time for flights of fancy or to introduce completely new ideas. I want to use all the things that I already mentioned, build off that discussion, but acknowledge some real barriers because I actually want to affect some change. I want people to say, like, oh, those are the barriers. How do we change those? And then finally, honestly, I like to end with a nice sentence. I like to leave people feeling hopeful about the future, that this is like positive work. I'm not just pointing out things that are at fault. I'm actually thinking about some better place that we can all go together. So creating climate justice within criminal justice. For hospitals, aligning policy or shackling of incarcerated patients with policy guiding restraint of non-incarcerated patients. So for example, giving like concrete examples of how we can make changes. Acknowledging safety concerns of staff. So what is that other side? How do we actually address that, for example? I think that's real. Whether it's real or perceived, it's still something we need to talk about. And like if that's a barrier, let's address it. Example. And then finally ending with that nice sentence. So when we view incarceration as a chronic and life-threatening condition affecting individuals in the carceral system, their families, and our communities, sensible criminal justice reform becomes a clear and urgent healthcare platform. I'm pretty sure Bree wrote that one, to be completely honest. Give a shout out to Harvey Milk, because I'm a native San Franciscan. But I think about this when I'm ending these pieces. And so the only thing they have to look forward to is hope. You have to give them hope. Hope for a better world, hope for a better tomorrow, hope for a better place to come if the pressures at home, which are great. Hope that it will all be all right. have a couple minutes, or am I over? I can talk about some nuts and bolts here.
If you're amenable to opening up for questions, I think it'd be a great time to do it.
For sure. Yeah.
And I heard a rumor Melissa Gerald had a question. Melissa,
Okay.
do you have a question?
I do. I found this absolutely fascinating. That was really, really an interesting presentation. And
Thank
now there you are. Okay, very good. I'm like looking for you here on the screen. So that was really interesting. And I'm just thinking to myself, what at what point should people be writing perspectives versus research articles with respect to their stage of their career? When are you, one, like an authority on the topic to speak, to these various topics? And especially if you're also trying to advance a research career and how that's maybe perceived. And my second question, I don't know if I can articulate this well, but when we're thinking about gold standard science and how sometimes perspectives have been confused for data findings that as the basis for making various policy changes. I'm just trying to
you.
think these things through, the costs and benefits. And so I'd really love to hear
Mhm.
your thoughts on that as somebody who's done a fantastic job at in publishing the highest of quality pieces in this, I guess you could say, genre. And that was plural. And
For
so
sure.
the genre, just to let you
Yeah.
know. Thank you. I hope that was clear. Sorry.
Yeah. Let me, I'm happy. Thank you, Melissa. I appreciate the question, and I appreciate your support of the network as well. But here's a big asterisk. I don't pretend to be the expert on this, and I think maybe I have a little bit of an atypical path in terms of coming at this as well. With regard, and so I'd love to just open it up for other people's perspectives as well, but I'll reflect on those two questions. In terms of the stage of career and authority on the topic, I actually often get approached by, because I work within medical, like UME and GME kind of education. So I'm often approached by medical students and residents who are really interested in this, and they're really interested in social justice topics. I work at a safety net hospital. I attend on the ward. So I think I'm like a pretty comfortable person as well for them to come to. And they're interested, and they may have that same kind of question. I personally think that there's no particular stage of your career where you have to have like gotten to before you can demonstrate expertise in these. And I think that all of those stages actually have really valuable voices to share. So for example, like the medical student voice, I think within medical literature in general is so absent. And yet they're doing 4 or more years of medical education. Some of them are MSTP, MD, PhD students and stuff. They're really interested in this. They're of a completely different generation and era than I am too, and have a different understanding of the world. So I talk to them a lot about sharing their experience, because I think they can actually talk to their personal experience with this topic much better than I could, and much better, like in a way that I would have to, go through all kinds of contortions to get like a qualitative group together to do this study, which is valuable as well. I think Aaron's actually doing something like that, in fact. So I would encourage them to like think about what's unique about their voice at any stage of their career. Like, what does it look like as a medical student? Why am I not being educated about the care of, patients who are incarcerated and hospitalized, or care of, care within carceral facilities, or the rights of immigration detainees to acute medical care, for example. Like, why am I not hearing about that? Why is that part of a null curriculum or a hidden curriculum? Why isn't it part of a formal or informal curriculum? And so, like, I think to use voices. So in short, I tend not to think that there's one stage of your career that you have to get to before you can exert some sort of authority. You can be authority within your own kind of domain. And I think all those voices can be championed. And then the gold standard science and confusing perspectives with those, I'm totally with you. I think I tend to err on the side of making any perspective I write into essentially a mini narrative review. And that's where I
That's
always err. And I feel like that for me feels like a very safe space as well to be in. because I want to make sure that the statements I'm making are supported by evidence or are grounded in real world practices or examples of things that are kind of on the horizon. For example, you can Google this resource and see for yourself what it looks like, etc. So I always err on the side of trying to ground it a little more in like a 1,200 word narrative review at the end of the day, rather than really my eminence about anything. But I'm totally open to what others would say.
This
That's
has been so
super.
great. Oh, sorry, Melissa.
No, 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 no. I'm just was saying that was, yeah, super interesting. There's a lot for me to think about in terms of yeah, I'm just thinking about how many times I might have wanted to speak on topics I was very familiar with and earlier on in different stages of career that probably would not have been to my best interest as I was growing up in the ranks. I don't know. It's these are trade-offs and they're different topics altogether. So please don't take that literally.
Well, can I say one more thing? Sorry, I don't
Please
mean to
do.
belabor it. I know we have limited time, but I think
I
it's
think I
also a
would.
wonderful opportunity. You know, what I even have down here on this slide around considering co-authors too. And so I think even if you don't feel comfortable at the stage of your career being the resident expert in this topic, if you have an idea and you've looked through the literature and you don't think it really exists or you disagree with something, like this is an amazing opportunity, I think, to seek out mentorship. And I think like a community like this, for example,
I
is
love
this
that.
one.
Love that.
Yeah. And I think like, and that's where I found a lot of mentorship, for example, from Bree in this work, a lot of community and folks who are part of this network as well, in terms of like collaborators, writers. I also look outside of like my MD circle. I have a good friend who worked for the Office of the Federal Public Defender in New Mexico, and he's like my best friend from college. It's a wonderful way to stay in touch, and I learned something, and he brings this like really interesting legal perspective as well. So again, I think even if you are not the nation's or world's leading expert in this, it's an opportunity to actually reach out to somebody and to create this group of mentors and collaborators.
I love that. I love that. Thanks. Thanks for helping me to understand this. Thank you very much. A great presentation. Thank you.
If you would like to present something, tell me, let me know, tell one of us, and we will get you on the schedule. You look out in your email for upcoming events. I think our next one's in November. Totally meant to look up the date 3 minutes ago, didn't do it. Can't tell you when it is. Maybe Jamila can. But our next one's coming up soon. And look out for more announcements that are coming. Thanks all for being here. Appreciate it.
November 20th.
November 20th. Thank you.
Bye.
Thank you.